Good morning, everyone, and thank you very much for inviting me to speak to you today about the issue of public healthcare reform in advanced and emerging economies, which we at the IMF think is one of the key economic challenges of our time. The presentation I'm going to give you this morning is based on a book which we've recently published, and there's some copies on the tables, and I think you have the first summary chapter in your delegate packs. What I'd like to do this morning is focus on three themes. The first two will confirm any prejudice that you may have that economics is the dismal science. The third will hopefully uplift you from the depths of despair and set a bit of a framework for the rest of the day. Let me start with the first theme. We sometimes joke that the term IMF, the acronym IMF, isn't actually stands for International Monetary Fund, that it actually stands for It's Mostly Fiscal. Because we've been known to, when we discover any problem in any economy, we kind of say it's mostly fiscal. That will be my first theme, because there are huge fiscal challenges in the advanced economies. My second theme will be, though, that it's mostly health. That if you look at what the big drivers of public spending are in most of the advanced economies, it is mostly health. I'm afraid to say it, you are it. The emerging markets look very different. They're at a different stage, they've got a much lower base of spending, and they've got a bit more room to grow. But what I'd like to do, well, let me tell you, the third theme, which is the more hopeful one, is we can be healthier and fix the fiscal mess. Containing spending doesn't necessarily mean worse outcomes, but it's critical to learn from cross-country experience in order to figure out how to do that. And that's what I'm going to try and do today, is try and give a sort of more global perspective of the broader trends in both the advanced and the emerging economies. So let's start with the first theme. It's mostly fiscal. If you look at the scale of fiscal consolidation that's required in most of the advanced economies today, it is formidable. We haven't seen public debt levels at these levels since the time of World War II. And as you can see, where we are today, the Great Recession, as we now call it, we are approaching those World War II debt levels, and the debt levels are actually projected to continue to remain high and continue to rise for a few years to come. So the biggest economic challenge facing the advanced economies is how to stabilize those debt levels and start to bring them back down to more reasonable levels. That's why we sometimes say the first commandment at the IMF is, thou shalt have a medium-term fiscal consolidation plan, which fortunately the UK does have, but many of the large advanced economies, particularly the US and Japan, don't have, and that's a big issue. If you look at the emerging economies, you see quite a different story. Their debt ratios are actually far lower, and actually in the recent periods have been on a declining trend. So they're in a very different place. What everyone faces over the years ahead is coping with age-related spending, what we define as pensions and health spending. We project that pension spending will go up by about 1% of GDP until 2030, from now to 2030. In the emerging economies, we expect pension spending to go up by about 2% of GDP between now and 2030. So that's the pension piece of the story. But let's turn to healthcare. So let me turn to my second theme, which is it's mostly health. This shows you in the advanced economies the pattern of health spending since 1970, so basically the last 40 years. And what you can see is that over the last 40 years, we've had a steady increase in spending on the health sector, led by the public sector, where we've now reached a stage where most advanced economies are spending 12% of GDP, 12% of all economic output on healthcare. And that the public sector share has increased from about 3% to about 7%. If we look at the emerging economies, we see that they're in a different place. First of all, you've got a much lower level of spending, about 5% of GDP. And the public share has only grown by about 1% of GDP over the last 40 years. But the meta story is, as Virgil once said, the greatest wealth is health. As we get wealthier, we want more of it, and we want more of it at an increasingly growing pace. What does the trend look like going forward, though? How do we see healthcare spending moving in the future? Well, our projections are, if you look first with the advanced economies, we expect that the pressures to spend more are going to be substantial. We expect that healthcare spending will rise by about 3% of GDP in the advanced economies between now and 2030. And as you can see, when you look across the numbers, the rates are very different in different advanced economies, and the composition is very different. The US is the most extreme, where we think spending is going to go up by 5% of GDP over the next 30 years. And in European countries, you can see it's a bit less, but still, these are sizable numbers, at least 1% of GDP. It's also interesting to decompose the drivers of spending increases. The main drivers of spending increases, as you all know, are aging, technological advances, rising incomes, and health policies and institutions. People commonly think aging is the big driver, but actually, as you can see, it varies a lot by country. In some countries, the blue bit of the bar, which is the aging-driven spending pressures, are quite small, and there are other factors at play. In some countries, if we go to the end there, countries like Switzerland, Italy, Ireland, the main driver of spending increases is going to be aging. Now, you may notice, those of you who are aficionados of this field, that our projections are actually considerably higher than those of the European Commission's recent 2012 aging report. They anticipate only a 0.75% increase in health spending over that period. Over the next 20 years in Europe. The main difference between our projections and theirs is that they assume that health technology does not increase spending in the next 30 years. Our view is different, and that explains the very large difference in our projected spending increases. Let me turn to the emerging economies. And here you can see that the pressures for spending are lower, and the amounts of increase are also lower. We think public health spending in the emerging economies will grow by about 1% of GDP, in contrast to 3% of GDP for the advanced economies. And you can see there, too, the aging versus other factors story is just as diverse. So with countries like Poland, Hungary, Brazil having big challenges with aging coming ahead, countries like Pakistan, India, which are far at a different demographic stage, have fewer problems with aging and more cost drivers elsewhere. So the main challenge for the emerging economies is how to expand their systems, improve health outcomes, while not busting their budgets. That's their challenge. Okay, let me turn to the third theme, so just so you don't think I'm completely the Grim Reaper, and let me try and give a little bit of hope about how we're going to solve this huge predicament. If you take a very simple measure, this is very crude, but a very simple measure of the relationship between health spending and life expectancy. This is for the advanced economies. I'll show you the emerging markets in a moment. If there was some positive correlation between you spend more and you get more life expectancy, you'd expect a positive linear line here. What you see is chaos. There's absolutely no apparent correlation between health spending and life expectancy. You see countries pretty much all over the map. This is for the advanced economies, and here are the emerging markets. Some countries spend quite a lot, get good outcomes. Some countries spend quite a lot, get very bad outcomes, say South Africa, for example. Some countries spend very little, Malaysia, China, and yet get pretty reasonable health outcomes. So quite a huge dispersion in the relationship between spend and health outcomes. The OECD actually found in a recent study that reducing inefficiencies by half in the OECD countries would actually raise life expectancy by 1 year, whereas spending 10% more on the health sector would only increase life expectancy by 3 or 4 months. So it's an illusion to think that simply spending more will improve outcomes. WHO estimates that 20 to 40% of health spending is wasted. Of course, this is a global number and there's lots of variability there, but mainly associated with the misuse of medicines, medical errors, waste, and fraud. So clearly greater efficiency is essential for improving outcomes. And of course, it's essential that when we do that, that we make sure that the needs of the poorest, who are often the most vulnerable from these efficiency drives, are taken into account. So let me turn to what the options are then for greater efficiency and reform in the health sector. And I should start by saying these are patterns that we see in different countries. We're not saying any one particular approach is better than the other, but it's illustrative to look at the different ways that countries have tried to cope with rising spending pressures. So what have countries done to try and contain public spending growth in the health sector? First, budget caps. Many countries set a cap. In Italy, for example, there's a strict budget constraint at the regional level that has to be met. In Sweden, the budget constraints are defined at the sort of county level. They've been pretty effective at containing costs. It's very important, though, that the caps are set in a sensible way so that you don't just transfer costs to other bits of the system that aren't capped. And it's also obviously important that caps are accompanied by micro-level reforms to improve efficiency, such as competition and choice. Second, case-based payment systems. Countries like Germany and Italy, the US, under managed care in the 1990s, used case-based systems as a way to improve the efficiency of spending. This is in contrast to systems which rely on fee-for-service provider schemes, which fail to penalize treatments which are more costly than needed. The third approach is competition and choice, which countries like Germany and Japan have used, allowing more private provision, increased competition among providers and insurers, a debate that I know has been ongoing in the NHS for years. Greater reliance on private financing, demand-side reforms, and increases in cost sharing have been used in Australia, Canada, France, relying more on private insurance to cover things that are not provided in the public package. And those, again, have had to be combined with protection for the poor and chronically ill to ensure that their needs are covered under these more private options. And then finally, restricting the supply of health inputs and outputs. Supply constraints like regulating the workforce, equipment, the use of health technology assessments in countries like Canada have worked to contain public spending growth. For example, there is evidence that where you have more surgeons, you get more surgery. And in healthcare, something that we in economics call Say's law, supply can create its own demand. If you reduce supply, demand diminishes. Let me just say, not all of these reforms should be implemented in every country. Obviously, country circumstances are key. But I think we shouldn't underestimate how much some of these reforms can deliver in terms of savings. We estimate ranges between 0.1% of GDP and 0.5% of GDP. And some countries, like Germany and Italy, for example, have been able to contain costs and continue to deliver quite a good level of health services. Now, there are other measures which are a bit harder to quantify the benefits of, things like health information technology, very complicated, I know, but could help improve efficiency. Similarly, greater emphasis on primary and preventative care, as we all know, usually has very high payoffs. Let me turn quickly to the reform options for the emerging markets. There, the situation varies a lot by region. If we look at Eastern Europe, those are countries which have more or less achieved universal coverage and have pretty high levels of public spending on health already and have limited fiscal space. So for them, the focus is quite similar to the advanced economies, very much focusing on increasing the efficiency of spend. And so we've seen countries like Estonia, Hungary, and Latvia try and use cost containment reforms, for example, by having a single insurance fund. We've also seen micro-level reforms in Eastern Europe to provide greater incentives for primary and preventative care to deal with high levels of alcohol and tobacco consumption, for example. If we look at countries, emerging markets in Latin America and Asia, however, you have a very different set of issues. Those are countries where where coverage is incomplete and they aspire to universal access, but they haven't achieved it yet. The fiscal pressures are a bit less pressing, and there is some room for judicious expansion of spending. I think the key issue there will be doing it in a way that's sustainable. So clearly looking at finding ways single-payer systems is one thing I wanted to mention. I guess our view is that single-payer systems have, especially for emerging markets, some huge advantage over multiple payer systems. Countries like Estonia, Korea, and Taiwan have introduced single-payer systems recently, which have been able to reap economies of scale and lower administrative costs. They're also much better at delivering equitable outcomes. So we think single-payer systems are quite a good option for emerging economies. We're also of the view that the benefit packages need to be restricted to those that cover the most essential services. So really big health systems like China, India, and Mexico, which are now rapidly expanding and hoping to deliver universal health packages, need to focus those packages on what they can afford at the moment. And of course, improving the composition of spending is key. So let me try and summarize what the options are going forward. For the advanced economies, it really is the economic challenge going forward is really mostly fiscal and mostly health. The fiscal adjustment needs are huge, and health spending increases will add to those needs. It's critical that health reforms help contain those spending pressures, because frankly, there are very few other options. Increases in health will squeeze out other priorities if they aren't managed in a sensible way. We think the most effective strategy involves a mix of macro-level controls and micro-level reforms to improve spending efficiency. If we look at the emerging markets, the fiscal adjustment needs are pressing, and there are, again, a few cases where that's a big issue, and some economies are vulnerable. But most emerging markets have a bit more room to maneuver. Clearly they should focus on efficiency enhancement so that they get as much as they can, particularly in emerging Europe and Eastern Europe, where the fiscal room is a bit less. But really, particularly in Latin America and Asia, the coverage expansion really needs to be managed in a way that is consistent with preserving the sort of good fiscal positions they're in now. So I hope after the initial horrible numbers, I haven't left you feeling too grim. I think we can be healthy and wealthy if we are wise. But I'm well aware of how complicated it is to deliver some of these reforms, and many of you in the room are at the forefront of trying to do that. I very much hope you are successful, because over the next few years, the policy choices in this area will have huge outcomes, not just for the health sector, but for the well-being of the macro economies of the advanced economies in particular. It will be in many ways the most decisive set of reforms for the economies of the world. So I very much wish you success, because as people who care about macroeconomies at the IMF, your success will be ours. Thank you very much.
Thanks so much, Minouche. So what we're going to do now is I'm just going to ask Minouche one or two questions, and then I'll just open it up to the floor. So have a mull over what you might like to ask. Minouche, the first thing I really would quite like to ask you is, do you think it's possible to bend that curve? Or are we really thinking that the policies, the reforms that you're just describing that you see are not going to be able to do the trick, and the question is then rather how better to raise more funds for health? What's the view at the IMF on that?
I mean, it's really a question of how much more can you tax? And countries have very different approaches to how much of a tax burden they're willing to put on their societies. But it varies. Some of the advanced economies in Europe already have pretty high tax burdens, and I think have reached a bit of a limit in terms of how much more they can tax their populations. The US, I think, is quite different. The tax burden is quite low. They've got room to tax more if they want to. So it's quite variable, but I think for most European countries, there are a couple of exceptions, some of the Eastern European countries and so on, but for most European countries, there isn't a huge amount of room to raise greater revenues.
I mean, I was interested in your graph because if you saw Sweden was at the very right end of that curve, which showed that actually it's got practically flat excess cost growth, I think, as you describe it in your book, and actually most of the cost growth will be through demographics, which is fairly small. So they've seemed to manage on flat real increases. And I was quite, in a sense, they don't really make up a great, there's not a great focus of them in the book, but that's quite an interesting example, isn't it? I mean, do you have a particular view about Sweden and indeed Denmark that wasn't far behind, how they've managed to do it when in their system?
In the flat. I am not an expert on the Nordic healthcare system, so I wouldn't venture any conclusions there. But I do think it's precisely those kind of results that are worth digging into to try and understand better how they've organized their systems. As I mentioned, they do have these strict caps. They're obviously finding ways to ration services at the regional level. But the specifics about how they manage that, I'm not sure.
They're spending twice as much as a proportion of GDP on social care for older people.
Okay, so it's they're spending twice as much on social care is what Nigel is saying. So therefore, is it a definitional issue, you think?
No, I think it's probably
prevention.
Helping them contain their costs in the healthcare system.
Yes.
That's interesting.
Okay, that's interesting. Thanks. So the book, which I recommend that people have a look at, it's a very interesting selection of case studies around the globe, actually, as you were describing very helpfully. Some of the most successful strategies are the ones that we are indeed trying here, you must have noticed. Do you have a view, given the state we're in financially, does the IMF have a view about what we are doing in healthcare vis-a-vis our reforms? And if you do have a view, how are you exerting that with the officials here?
I mean, we don't have a view on the specific healthcare reforms. I mean, where we have a view is an appreciation that that the UK has a plan for medium-term fiscal consolidation, which is good. We're worried about the lack of growth in the economy, and we have said that if growth doesn't pick up, we had sort of said early this year that that one should look again at the pace of fiscal consolidation and the composition of it. The issue of health spending within that is delicate. I know the health budget is protected, and as was the budget of my former department, so they were the two sort of holy grails. I think given the upward pressure on spend, I think keeping it flat is probably quite difficult in and of itself. So going further than that is going to be very tough. But I think, I think there's as the international evidence shows, there are ways to do this. And I think, the NHS has been at the forefront of experimenting with a lot of precisely the reforms that we've seen in other countries. And I think taking those successes and spreading them around has got to be the way forward. I mean, I think there is, I think the alternative of trying to raise tax to continue, the question you had in your survey, I think given the state of the economy, given where growth is, I think it would be very hard to go there.
I was reading, you had a very interesting report on your website, which was, I understand, the Portuguese authorities called you in and you were advising them clearly about some of their macroeconomic policies. A key feature of that was healthcare, and a key feature of that was pay. And it was rather traditional belt-tightening medicine that was the IMF dished out in the case of Portugal, as it seemed. But I'm interested to know, to what extent do you think that pay can be held down successfully over a more than a short-term period? I mean, we clearly have got this issue here. 70% of the budget, upwards of 70% is pay. We've held it down, but everyone's sort of a bit nervous. There might be a pay bounce at some point. What do you see around the globe in the countries that you're formally advising? How to keep that sort of government, public sector pay down in a permanent way rather than just a kind of short-term cut way?
Yeah. I mean, for us, the key issue is the relationship between pay and productivity. So we don't just look at pay, we look at that relationship. And the more productivity you achieve, the more you can afford to raise pay. So I would look at both sides, because they're both variables you can manipulate. And in countries like Portugal and Greece, the problem was that pay had outpaced productivity for years. And they've been sort of out of whack with their peers for quite a long time. And so if you look at minimum wages, average pay has been growing quite fast in those economies. If you compare, let's just say, Greece or Portugal to Germany, pay has grown much faster in Greece and Portugal than it has in Germany. So that's unsustainable. And of course, with labor markets being more mobile, you are competing with those other countries. So it's a big problem if people are too far misaligned. I think the way to deal with it is to do these kinds of efficiency gains which will increase the productivity of workers in the NHS, and then that will give you room going forward to increase pay. I mean, it will also affect numbers, because part of the productivity story is having fewer numbers, but that may be a better outcome.
And around in all your travels around the globe, in emerging and emerged economies, as it were, are there really any good examples that you could point to on that particular challenge on productivity? On productivity. Or is no one doing it right?
I think there are good examples of pieces of different pieces of the productivity story. So, Turkey has been hugely successful using health information systems to increase the efficiency of drug use and various other things. The Chinese have been slowly ramping up their system in a way with quite modest costs in terms of pay. I can't think of one case where I'd say, aha, this is the best system. It's different countries have got different bits of things working very well to contain costs. But as you saw from the charts, they're very different. They're very different approaches in different places. So I think the thing to do is to kind of shop for this health information system, which increases productivity, this kind of reimbursement and payment system to contain costs. I think that's really the way forward.
Okay, thank you. And one thing I thought was quite interesting, and there were a couple of areas in the book which I thought had mixed messages. And let me try these out on you. So the first was that some authors of these chapters seem to think that controlling prices was not the way forward. And yet some of the countries that you quote as being particularly successful in their smorgasbord of reforms had price control as central, regulated prices as central in their, Germany, for example, and the Netherlands and so on. Where do you have a particular fixed view about regulated prices? I ask because clearly we haven't had that much of a debate here, but there's still some debate around the edges, despite the fact we are moving towards trying to cover as many prices as possible in a regulated way.
You know, I think we don't have a particular view on pricing issues in the sector. In general, we kind of like prices because they help allocate resources a bit more efficiently. But I think in this sector, it's different. Given the nature of demand. So I think we're more worried about the total cost, and if regulated prices help you get there and they don't result in too many distortions, I think we prefer not to kind of micromanage quite at that level of detail. I think for us, the sort of macro critical issue is the total envelope and where that ends up. And as you said, countries have taken very different approaches to this issue. Some have allowed prices to fall where they may. Others have used regulation. I think we're kind of agnostic at that level. But where price regulation hasn't worked and has resulted in misallocation, I think we'd be a little bit cautious.
Okay, and just the other area which I thought was you could see from our slides earlier, was the area of competition, particularly not so much insurer competition, although that's something that is plugged in the book, interestingly. It's more provider competition. And some chapters are saying that it has a, you know, obviously we're describing the effects in different countries, but the macroeconomic modelling in that simulation chapter seemed to think that of all the things that you can do in reform, that competition amongst providers was the biggest element that's going to get us the productivity gains. Again, is that just one study, or is that tending towards a stronger IMF view about the role of competition in provision, particularly?
No, I think we do think competition on the provider side is very, very powerful. Clearly, different countries have different views on this, but there is no doubt that having, you know, for the payer to be able to compare different prices and different services is very powerful. You know, whether that's a single payer system or a multiple payer system, it must be helpful to get signals from different providers. And, you know, as we all know, when you have one provider, there is opacity on costs and what's driving them and knowing what you're getting. And so I think we would feel that from the consumer and the payer side, it is hugely advantageous to allow some competition among providers.
Good, thank you.